Well, welcome. Order. This is the last session of the Health and Social Care Select Committee's inquiry into adult social care reform, the cost of inaction. And it is our delight to start our last session with three amazing people, three unpaid carers, two of whom are young carers. And we'll start, please, with questions from Jayne.
Thank you, Chair. Good morning, and we're very, very pleased to have you with us this morning. Nice sort of easy question to start, I guess. If you'd just like to tell us a little bit about yourself and your experiences as being carers and young carers. I think if we start with Holly and then we'll work our way along.
Yeah, so I'm Holly, I'm 22. I grew up as a young carer. So I grew up with my mum and my sister and supporting my sister who has a range of conditions including epilepsy, cerebral palsy, hydrocephalus. When she was born, the doctor said that she would never walk or talk, but she ended up doing really well, and she went to a mainstream school with a full EHCP plan. So although I wasn't the primary carer, I was often involved with helping her do her physiotherapy exercises, sometimes helping her have a shower, dry her hair, things like that, sight guiding her out in public. When she was about 17, she lost even more sight and became severely sight impaired, so that was quite an adjustment. She had a lot of hospital stays in and out. She's in double digits now of surgeries that she's had, including many on the brain. So I'd often be providing quite a lot of emotional support. But I think it's probably also slightly the single parent family dynamic that sometimes my mum just needed an extra person to talk things through. So whether it was for example with the school, if her EHCP plan she wasn't getting the full support, what to do about that, or whether we should ring 999 or 111 right now, and all of those kinds of things. So although I'm not the primary carer, I have, I guess, still played a role. And yeah, I mean, I consider myself quite lucky compared to other young carers my age. But I think caring is quite a fluid, flexible thing. So I'm obviously away at university right now, which has meant my role has decreased. But I think as I get older, I'm probably going to have to take on more of a role as, my mum becomes less and less able to care for her.
Thank you, Holly. Keyaan, how about you? What's your sort of experience?
So my name's Keyaan, I'm 14, and I look after my mum and my brothers. My mum has epilepsy and some other disabilities which help, like muscle diseases, which doesn't help for housework. So she'll often need extra help with carrying stuff or looking after the babies. And my brother who's 10, he has ADHD, and he often needs help with behaviour management and stuff like that.
Thank you. And Jayne?
I'm Jayne Simpson. I won't give my age, but I'm much older than Holly. I care for my adult daughter who's autistic and has complex mental health issues as well. And as a result of her autism and her mental health issues and the inequalities that brings, she's now starting to develop physical health needs as well. She lives in the family home with us. She requires support to be available 24 hours a day. Her needs are very complex. She has a lot of needs around being kept safe. Without our support, she would have a very diminished life and really wouldn't be able to function. We do get 14 hours of support from our local authority, but in reality that's much less than 14 hours because there's difficulties in the care provider providing all of those hours with adequate and well-trained staff. Alongside caring for her, I'm in paid employment. I can only work part-time and I have to work from home. It's barely possible for me to leave the house. Something like today is quite a rare event to be able to leave and have adequate care for her. And alongside that, as a result of being a carer, I do a lot of lived experience work. I'm a parent-carer representative on the West Sussex Autism Partnership Board. I'm an expert by experience with Sussex Partnership Foundation Trust, who are our local mental health provider, and I'm also involved with Care Support West Sussex on their Carers Voice network.
You're a busy woman, basically. A very busy woman. How does your work react to your sort of caring responsibilities? How does that tie in?
Well, as I've said, I can only work part-time, and I've only been able to take a 0 hours contract now. When I began in the job I'm in, which I've been in for I think 21 years now, I had a substantive contract. I had, fixed hours like my colleagues did. I was able to, if you like, play a full part of the team, but I've had to very much reduce that as a result of being a carer, and that's brought a lot of difficulties financially to be 0 hours, much lower pay than my colleagues get for being 0 hours. It's affected my pension. I don't have a substantial pension to make any choices about retirement in the near future, which perhaps I would have been doing, and I'm very concerned because as it stands I won't be getting a full state pension because I've lost national insurance contributions as a result of being part-time and 0 hours, which can be I don't always know what hours I'm going to get each week. It can work both ways for my flexibility, but equally so my employer doesn't have to give me fixed number of hours. So it's brought a lot of difficulties with my employment, and really my career stalled as a result of being a carer.
Thank you so much. I'm just going to pass back to the chair.
Did you ever add it up? How much you lost over the years?
I haven't actually. I suppose for me the very tangible one is the pension, knowing perhaps what I might be getting, and knowing about the gender divide in that my husband is also very involved in supporting our daughter, but he's been able to keep full-time employment, I think because of the tradition that caring tends to fall to women. It was much easier for me to be part-time than it was in his role. It wasn't seen as a possibility for him to go part-time. So I'm seeing now that he has that choice of retirement, and he has, an adequate pension he'll be able to live off. I don't. So I'm afraid I can't give any figures. I haven't sat down and worked it out. But I just know that, I'm not in a great financial position. I lack financial independence, actually.
Thank you. Thank you all for coming today. So I guess one of the things we're trying to think about is what the cost of the fact that the care system doesn't, the social care system doesn't do everything it needs to do. So I want to just kind of ask you all a little bit about how it's kind of impacted you personally in terms of what you're able to do, in terms of how it kind of gets in the way of other things in your life. So that's kind of what this question's about. Don't feel you have to kind of answer all of them, but if we just start kind of with Keyaan, do you think it kind of being a carer limits your ability to be involved at school? Does it limit your ability to kind of socialise with your friends or take part in sports or anything like that? Do you think it has that kind of impact on you?
I'm not sure.
Not sure, no. And in terms of Holly, so obviously kind of looking back at your school experience, do you think it's had a kind of impact on both that kind of social side but also your ability to participate more generally?
I think I've been very lucky compared to a lot of other carers. We know that on average young carers are missing a month's worth of school every year, and half of young carers are missing 1 day of school every fortnight. So compared to that, I have been very lucky, but like I mentioned, my sister was in school with me on a fully HCP plan, but I know that there's also a SEND crisis and it's really difficult, and so I don't blame the school for this, but there were times where she lacked a TA, so most break times sort of in Key Stage 4 towards GCSE years, I would make sure she had something to eat, drink, occasionally help her get changed for PE. In between every lesson, I would go to her lesson, sort of sight guide her and walk her to the next lesson, and then go to mine, which at the time felt fine until things go wrong. So she has anxiety. She sometimes had moments where she got really overwhelmed, and I'd kind of have to deal with that and try and get her to eat something. And then I remember once running then to a speaking exam. So it was quite intense that I didn't really have that break, and my mind was always wandering. I think obviously I've been lucky, I've been able to go to university, but a lot of young carers I know in youth groups and stuff either haven't gone in order to be able to be eligible to still claim carers allowance, or they've gone and dropped out, or they've stayed very local. So yeah, I'd say that's much more of a common picture.
And obviously, Jayne, you talked about a bit about how it impacts your kind of ability to work. I assume that there's a bit of a read across to the rest of your life in terms of the impact.
Yes, very, very much so. And I think sort of before I go on to say a little bit more about how it impacts me, I do want to say it was a difficult decision to come here and talk about the impact on me, because that also then impacts on my daughter, that she already has a sense as a person with disability of perhaps being a burden, perhaps being unequal to others in life. And it's very difficult to talk about the impact on me without that passing on guilt to her. So, it is a really difficult thing as a carer to have to talk about that impact on your life and the effect that has on your family. I would say, yes, it has wide-ranging effects. Health, I would say that caring has got much harder in the last few years, much less support out there, services just are broken, so, that's having a major impact. Mentally, it's not just the mental strain of actually caring for the person, of the worry of keeping them safe, keeping them well, keeping that going. It's the mental strain of actually, if you like, doing battle literally every day to get the help you need from whatever service that might be. That has a real psychological impact in that life can feel extremely negative, that so many conversations every day are about difficult things, not getting what you need, and perhaps feeling that you're being you're being too demanding, and that's quite hard. I've already talked about work and finance, that's a massive impact. Relationships with other family members. We have 2 other daughters. It's trying to find times that you give equal time, and that can be really hard when you've got someone in the family who has quite high needs. Friendships, you find friendships drop off when you can't leave the house, when you can't be reliable about making arrangements, when you can't go along and feel free to just sort of talk about the things that you've been doing. You feel that people don't want to keep hearing about my caring role. That has a real impact on maintaining friendships and relationships generally.
Thank you. I mean, I hear what you say about kind of not wanting your daughter to see the negative side. I'm sure you'd sort of conversely say that, of course, like spending time with people that you love and supporting them is a privilege. So even if it, I think we should understand that. But the job of society is to balance that, to make it easier and possible. And I think that's one of the things that we're looking at today. You talked about the kind of the mental strain. Do you find it easy to look after yourself and your own health? So one of the things that came up when we had Skills for Care and a few other organisations here was they said that the carers at home often will miss their medical appointments. They'll miss looking after their own health and well-being. Do you find you sometimes fall into that?
Oh, absolutely. I would say my health comes very much bottom of the list. When you're a carer, I think your focus is absolutely on that person you care for, and particularly if they have high needs. There isn't time. If you've spent hours trying to get through to a GP surgery, trying to arrange a hospital appointment, trying to arrange social care, you haven't got time to then do that for yourself. So you tend to leave that at the bottom of the list and think, I'll be okay for another day, I'll leave that. But of course that accumulates, and in the end you're going to end up with a problem. So I would absolutely say that it really has affected my health, and being able to look after that and plan for good health for the future. You can't do that.
Holly and Keyaan, do you have anything you want to add on the impact side of things? Keyaan, you run, you're the lead student young carer at the Swan School. Tell me a bit about that.
I help at Swan, like organising events, trips. Like we're at the moment looking at getting Annalise Dodds down to the Swan so we can talk and see what she can do to help young carers at schools. I help make young carers' lives at school much more fun within like the time we get, because we get 40 minutes on a Tuesday and a Thursday. On a Tuesday we get a homework club where we get to have 40 minutes of homework, or on a Tuesday we've had Emir Steve Ali, who's a politician for Oxfordshire, who came down and spoke to us about what he does, and what he could do to help young carers. And on a Thursday we get free play and stuff, basically.
Lovely. Holly, when you were at school, what was your experience at school of support for young carers?
I was really lucky. So Centre 33, which is, I grew up in Cambridgeshire, so they support young carers in Cambridgeshire and Peterborough, and they ran a group in the school. So I was identified through them doing an assembly in my school. Again, I think it's probably important to stress that my experience of having so much support, and I was offered a transition assessment and everything like that, is very rare. I mean, I think on average young carers are waiting 3 years to access support. You know, some you even hear of 10 years plus, and that's presuming that they know that they're a young carer in the first place. So yeah, I've been very lucky, and that support made a real difference to me, especially when I was considering university and applying, and I felt a lot of guilt, and it was coincided with a period when my sister's health was very unstable, and I think having that one-to-one support, someone outside of the family setting that I was able to talk to and express these quite complex feelings of guilt and feeling very selfish for wanting to go away, having that, I think, was ultimately what then did propel me onto university. So yeah, I just wanted to stress that my support and having so much is not common across all young carers.
Thank you. Paulette Hamilton.
Oh, thank you, and thank you all for coming today. My first question is really for yourself, Ollie, and yourself, Keyaan. Jayne mentioned that her daughter receives 14 hours of local authority care each week. Is it, Jayne?
Yes.
Do you know how much your sister receives each week? How much, Ollie, does your sister, local authority care, does your sister receive each week?
Currently 10, I believe. I think potentially in future years that might change. I know at the moment, so obviously I guess my mum is in the same position as Jayne as a parent carer, is filling in a lot more hours than the 10 that's provided. And, you know, my sister kind of wants to be as independent as possible, so it's about doing it in a very kind of respectful way where she doesn't feel that she's being cared for as such. But yeah, she currently receives 10. My mum also does a lot.
Keyaan, you've got both your mum and a sibling that also live with additional needs. Do they receive any local authority support?
I'm unsure.
You're not sure? That's okay. So my next question follows on quite easily. As someone that ran, I was a cabinet member for adult social care for 7 years, actually. The question I'd like to ask you is, how difficult was it to receive the care, Jayne, that you've actually received? And if you want to access more care or additional care, do you find that easy if you want to go away or do anything? How difficult or easy is it? Over to you.
It's extremely difficult. I think in our case, the funding hasn't been the issue. We've been funded for a lot of care over recent years. Our daughter was previously in a residential home, then in supported living, both of which broke down because of the poor service both provided, again through recruitment and retention issues, staff that we had so many different staff coming and going with our daughter that it caused a huge anxiety and actually made things worse rather than better. So hence her now being back at home with us, because it was felt that that would be better actually for her than the care that was originally being provided. And the difficulty is I feel like I'm managing that package of care. It's provided by the local authority and paid for, but there's no accountability, no one who's checking if people do turn up and the quality of that care. I feel that's all on my shoulders, and when it goes wrong, on my shoulders to sort that out and to then take the consequences when my daughter is actually further damaged by poor care.
So what was the care that your daughter actually receives? What does she actually get?
So her support is really to help her go out into the community, help her to have, if you like, a meaningful life. She doesn't need personal care, but she needs care to access the world. Her autism means her communication is a difficult area for her, severe social anxiety, so she's very isolated at home. So really the support is to provide that link with the world and to just give her some purpose in her life. But it's hard to get it right. I don't think we have yet. We keep trying. We have some brilliant staff that come, but brilliant staff that then leave because they don't feel able to stay in social care.
So, Keyaan, you may not be able to answer this, but I know you don't know how much hours the family gets, but what sort of care do you get at home from the external, or support, should I say, from the external services that come in?
I don't know.
You don't know. Ollie, any idea? What support? Or?
I mean, mainly the 10 hours. I mean, my mum, as a parent carer, ironically, is kind of too busy to sort of access really like support for herself, which I think is probably
That's
quite
a good,
common.
it's support for herself. Thank you for that, both. And this follows on from the announcements yesterday, and this is more for Jayne. I hope you guys don't mind. With the PIP payments, with the reforms coming through, what do you understand it to mean? How are you feeling at the moment as a mum who's looking after a young person with additional needs? How do you feel read the reforms?
I feel very scared about reforms. I don't feel positive about them. I found it actually quite distressing to hear the news yesterday and to wake up to it this morning, to feel that it's just another layer added onto all the stresses of caring and all the worries about my daughter's future. I'm particularly concerned my daughter does get PIP. I get carer's allowance, which, as we know, they're linked. If my daughter doesn't get PIP, will I stop getting carer's allowance? Does that mean I've got to go and get more work? How do I then, care for her? I'm, really, really very uncomfortable. I would have liked to have heard some more positive news about how we would support people to not need those benefits first before I heard that those benefits were possibly going to be cut. And I worry about, I don't know which category my daughter will fit into. Will she be seen as someone with very long-term disability that may not have to keep reapplying, or will she be seen as an autistic person that has the potential to do more in life? I feel she does have the potential, but the support we get at the moment doesn't allow for that potential to be utilised. So I'm really, really very anxious about it. It's just something else that's leaving my mental health affected by it.
Ollie, would you like to say anything regarding what's going on with the reforms at the moment, especially around PIP?
Just that I really echo everything that Jayne said. I had a conversation with my mum over the phone last night about it and what this might mean, 5 years down the line, 10 years down the line, as my sister is, sort of a fully fledged adult, and what that means. It really worried me as well. It's just a lot of unknown. And yes, I worry that, like Jayne said, that instead of people being supported not to need those benefits in the first place, that instead they're just being reduced before step one has happened. But I guess it's too early to
And my last question before I hand back to the chair, it's following on about the support. Thank you for that, Jayne. And it's to both yourself and Keyaan, Ollie and Keyaan. Yourself and Keyaan. You must rectify me. It's one thing I'm hopeless at. That's names. But anyway, Keyaan and Ollie. I'm a great believer that although you offer a lot of support to your family, where do you get your support from? Where are your support mechanisms? Ollie, over to you, then Keyaan.
So, like I said, Centre 33 supported me a lot growing up, and I know I'll let Keyaan talk about Be Free Young Carers, who are great, but they offered me like one-to-one support. I had free counselling through them. I went on trips, activities, things like that, learned to ice skate with them, things like that. It was really, really positive. And now I'm supported a lot by Carers Trust and do youth groups and things like that with them. It is such a postcode lottery though, so Be Free Young Carers, for example, they don't receive any local authority support. It really does vary from place to place. I was on a youth group with young carers yesterday, and there were some in Blackpool who were telling me that they wait years to get support in the first place, and when they get it, it's great, but it is really hard to
So do you think local authorities should be offering more support than they actually are?
100%. I think they have a duty to offer assessments, young carers assessments and transitions assessments, but the reality is that this doesn't always happen. Young carers don't know that they have the right to ask for this, and even if the assessment happens, it doesn't necessarily then lead to support. Like that's not a guarantee, and I think that's something I'd really like to see change.
Keyaan, would you like to add to that?
Well, I'm not really sure.
Tell us a bit more about Be Free Young Carers.
Exactly.
How often do you go to them? When did you start? When did you meet them? How did
And
you
also, why did you start going?
I heard about them last year through my school, in a young carers group, when Lorraine came over to the Swan, who's been coming quite regularly on a Thursday for our hangouts, and she told us about Be Free Young Carers. So me and one of our counsellors at school signed up for it. Then she came visiting to my house, and from there I've been involved with trips and meeting new friends and gone ice skating, walk park, stuff like that.
Can I thank you very much, all of you. Fantastic. Can I hand back to the chair? Thank
Quickly
you.
from Jayne Croft.
Thank you, Chair. I just wanted to pick up on something you said, Jayne, that you are concerned that every day feels very negative and you never want your daughter to feel like she's a burden. So I thought I'd just like to offer you all the opportunity to just tell us something about the people that you care for before we the Chair's going to wrap this session up. You know, what do you like about them? Why are they a fantastic person?
My daughter is really brave. She's been through an awful lot as a result of her autism and a lack of really good understanding and good care. She's had some dreadful hospital admissions that in places she really shouldn't be, but because there was a lack of support in the community, and she keeps going. Life is really tough for her. She's anxious about everything. The outside world is really scary to her, but she keeps going, and she keeps having hope that she will one day have the life that she wants to have. And she really cares about us as a family as well. She really does. Although with autism it can be difficult. We think people don't empathise. Sometimes they actually over-empathise, and she really cares about us as a family and will do whatever she can to make things better for us. And she has lots of talents, and I just wish we had the support in order for those talents to be used and for her to be a full part of the community and society.
Thank you so much. And Holly, would you like to say something?
Yeah, my sister has a wicked sense of humour. Sometimes when I'm sight guiding her, I pay so much attention to her that I end up being the one that kind of steps in all the dog poo and stuff, and she does like to remind me about that on a regular basis.
Yeah.
Well, I've got my brother who's very humorous, and he's a very funny person. He likes to make everyone laugh and have a good time.
Thank you. Thanks so much.
Oh, thanks, Paul. That's a lovely question. Thank you, Jen. Keyaan, what do you want to be when you grow up?
Politician.
Yeah?
Well,
You've clearly got the bravery. Don't do it, he says. No, you should do it, absolutely. Why do you want to be a politician?
Well, in COVID, the news was on all the time, and when I was listening to it, because Boris Johnson was the Prime Minister then, I heard a lot about COVID, about staying home and staying safe. And from there, I got really into politics and listening to all of it, and then the general elections, the council polls and stuff. So got really into it, and then
Fantastic. And Holly, what are you studying at university currently?
French and linguistics.
What do you want to do with that?
I don't know, something maybe with charity sector policy. We'll see what the job market looks like next year.
And you mentioned, Holly, that caring you think will feature continually in your life, but it's not stopping you from doing stuff either. But do you think about that, how that you're going to fit everything in as you get older?
Yeah, I do worry about it a little bit. Even I had work experience in your office and then had to pull out early due to caring situation, and I just don't know because it's so unpredictable. I really hope that everything will be fine, but you just don't know. Things could take a turn for the worse. So we'll have to see. But fingers crossed.
And Keyaan, is that something you think about, how family and your ambitions are going to fit together? Yeah. What do you think about it?
being honest, I'm not too sure.
Not too sure yet. Right. Well, you keep dreaming, keep going. And Jayne, in terms of the prospects for the future, is there a version of the world where your daughter gets sort of more independence, or do you just see yourself, this is your role? And
no, I mean, I stay hopeful. I think we have a really good opportunity to create a brilliant social care service. I'd like to see it have parity to the NHS. I'd like to see it valued, the staff valued in the same way that we value perhaps those that work in the NHS. We value them for saving lives. I think we value social care less for giving people lives that they want to live, and I think that's just as important. And yeah, I do have hope, but this is the moment that we really have to do something about this. As I said earlier, we have some brilliant staff that come to support our daughter, and I want those people to really want to stay in social care, not to have to say, but I can't afford to. I'm going to have to go and get a job at the local supermarket. People that feel they have to move on in order to get a profession that isn't available in social care, we don't see it as a profession, we see it as unskilled. And I really think that, that we need to look at reframing social care and reframing how people feel about social care, and that it is a lifelong service from the very young who need it all through their lives up to much older people, and we just need to up that image of it and that value of it. And then I think my daughter might stand the chance of having the life she wants to live.
You preempted my question, which was, the recommendations for what needs to change, what needs to be better in the system. Holly, have you got one? If you could wave a magic wand, which I don't have, but if we could, what would be helpful to you?
Yes. I'll try and be brief. I think there's two things. First of all, I think transitions needs to be a lot better supported. So there's so many young carers that drop out of university or aren't able to work. In the youth group yesterday, there was a young carer, Eloise, who said something really good, which I scribbled down. She said, when you're sort of a young adult carer, you don't really get to enjoy being a kid, but you can't really get to be an adult either. You're sort of left in this grey area. And I thought that really rung true, that you can't really access university and employment in the same way. So I think transitions is one area that needs to have a lot more support, but also I think the responsibility of adult social care services in general to identify young carers, because inevitably they are going to be interacting with young carers, whether that's through hospital appointments or anything really. And
how would we best do that? Where? In schools?
I think it happens already in schools, although the last school census, 72% of schools said they had no carers, which definitely is not true. But I think also in hospital settings, in GP settings, if a young person is accompanying a parent, for example, to an appointment who has a lifelong condition, they probably are going to be carrying out some sort of caring responsibility. So I think it's just in those sort of settings where external support is being provided to a family to look at the kind of wider picture and think, who else is providing support here too? Yeah.
Keyaan, is there anything about the system you would change if you had a magic wand? What would it be?
I'm unsure.
Not sure. So I will just offer one last word from you. You've got a room full of cross-party politicians wanting to help. Is there anything that any of you feel you didn't manage to get across today that you'd like to make sure that we know before we move on to the next panel? Jayne, is there any last words?
Yeah, I just want to get across that I want a service that I can really trust, that I can have a life too, have choices without guilt, but be able to trust that service really does give my daughter the best, not a service where I feel unsafe with it, a service that just seems to be, a bit of a mess. And I don't want to keep hearing carers saying, but what's going to happen when we're not here? Nobody else can care for my loved one like I can. We don't want to keep hearing that. We want to have people all having lives that thrive and normal relationships, not relationships that struggle because of that whole caring dynamic.
Thank you. Keyaan, any last words? No. Holly?
I'm really grateful for the opportunity. I think I'd also really like to see kind of changes to carers allowance at some point.
What changes do you want?
Specifically, there's a 21-hour rule, so if you're in full-time education, you can't claim carers allowance, and there's a lot of people I know in youth groups who are the primary carer, are certainly providing 40, 50 hours of care, and completing, university at the same time, and yet they're not eligible for it. And so that's something I would really love to see change.
Lovely. Well, we are very grateful to you, all three of you, for coming and sharing your stories, and to your loved ones for allowing their stories to be told too. So thank you so much for doing that. It's very brave of you, but it's really very much our pleasure that you were with us today. So thank you so much. We're now going to move on to the second panel, and you are very welcome to stay and watch. Thank you.
Thank you very much. Thank you very much indeed. Great.
Sorry. Where's that note?
No, it's fine. Yeah, thanks, Jen. That's a good point. That's a good point. Apologies.
Oh, brilliant, thank you. Oh, good, we can scribble. Love it. I think I've got one. Yeah. All right, if we can make a start. So may I welcome Dr. Maria Petrillo, have I pronounced that correctly?
Yes.
Thank you. And you're going to be presenting to us estimating the cost of informal care with a novel two-stage approach to individual synthetic control. So if I may, Maria, over to you.
Yes.
Thank you very much.
Thank you so much for having me today. Yes, I've been asked to present this paper. This is a joint effort with colleagues of the SRC Centre for Care, based University of Sheffield, Oxford, and Birmingham. So, next slide, please. So, the aim of this project, of this paper, are the following. The first one is to understand and give an estimate of the caregiving penalty, the income caregiving penalty in the UK, where we define the caregiving income penalty as the reduction in income because as a result of the uptake of unpaid care responsibilities. The second one is to investigate the relationship between the magnitude of this income penalty and the intensity of care provided, which is measured in terms of hours of care provided every week. The third one is to understand a little bit about the diversity of this caregiving income penalty. And in particular, we want to understand how does it vary by age, sex, ethnicity, and so on. To do so, it might sound scary, but we're going to use this. We developed this methodological approach, which is a new approach to the individual synthetic control that improves a little bit the accuracy in the estimation. And I'm going to explain in simple words just in a few slides. Next slide, please. So you already know that, but according to the latest census, millions of people in the UK provide unpaid care every single day, and the care they provide is worth an estimated 184 billion, which is, to contextualize, just equivalent to the combined NHS budget across the 4 nations. Now, the literature has been uncovering the penalty they face, which is a triple penalty: financial well-being, relationship well-being, but also health in terms of physical and mental health well-being. Now, in this very presentation, we focus on the financial aspect, so financial well-being. Balancing paid work with caring responsibility often leads to reduced productivity, declining work performance, and because the nature of unpaid care is so unpredictable, it cannot really be combined with fixed work schedule, and flexible work schedule, let's be clear, are very hard to secure. So unpaid care need to decide between a decrease in their working hours or leave the work entirely. Next slide, please. So this is not enough of a motivation of why we should care about this reality affecting million people. We can look at it at the macro perspective. There are few recent estimates from the ONS showing that the population age 85 plus is predicted to double by 2045, while the working age population will only increase by 5% and then flatline until 2035. Now, this raises 2 main concerns. The first one is that there will be an increased pressure on the social care system and on unpaid carers. The second one, we can look at that at the labor supply kind of view. We will see that 85 plus people are going to increase, meaning that demand of care is going to increase, meaning that many people will need to face the choice of remain in work, in paid work, or leave to provide unpaid care. Hence, we're going to have a shrink in our labor supply at macro level. Next slide, please. So, this individual synthetic control is a new approach. Let me explain a little bit methodologically when we want to estimate this penalty, what is the main issue. The main challenge that we have is that in order to estimate the penalty, we will want to know what would have happened to unpaid care had they not taken on unpaid care responsibilities. Now, this reality, this alternative universe is impossible to observe. We only know that unpaid care provide unpaid care. If we compare unpaid care with those who do not provide unpaid care, we're going to be comparing apples and bananas. So it's completely different. What we can do is to construct synthetically this universe. We call them the doppelganger. The doppelganger mimics exactly the unpaid cares. The only difference they have from the unpaid care is that they never uptake unpaid care responsibility. Hence, we can track them over time, follow them, follow their income trajectories, and if there is a change, we know that this is due to unpaid care responsibilities. We can see the doppelganger as a customized control group, allowing for more accurate comparison and better estimate of the caregiving income penalty. Next slide. In order to do this analysis, we relied on this data set called UK Household Longitudinal Study. Just to be sure, this is a national representative survey that follows individual and household over time in the UK. So we are able to track them down, follow their income stream, and try to understand what happens over time. Most importantly, these data have two precious information. The first one enables us to investigate into the carer status. The second one into the intensity of care provided. So we are able to identify our treatment group, unpaid carers, and we divide this treatment group in 4 subsamples. High intensity carers, those providing more than 50 hours of care per week. Medium high intensity, between 20 to 49 hours per week. Medium low intensity, from 5 to 19 hours per week. Low intensity, up to 5 hours per week. And then we have a control group, those who do not provide unpaid care responsibility for the entire span of our data. Next slide, please. Now, we want to measure caregiving income penalty. Income can have different definitions. Caregiving income penalty can be defined in lots of sorts of ways. We focus on individual income, monthly, household income, monthly, and income share. So how much I contribute with my personal income, my individual income, to the household income. In order to compare like for like, we adjust the model for some control variables. So we control for background characteristic, education level, ethnicity. Next slide, please. So this is just a graph showing really the data as they are. So before we actually do any adjustment, before we actually run our model, this is what we call raw data. What we can see is that on the horizontal axis, we have the age, vertical axis, individual monthly income, and then we have different shapes that describe what we call the age-income relationship, and those shapes have different colors according to the intensity of care provided. Now, the control group is the shape in red, in black. We want to compare this with what happens for unpaid carers. For example, let's do the comparison with the red line, 50 plus hour. You can see that those people earn less for every single age considered. Their income are lower than our control line, the black line, for every single age, especially for their working age. Next slide, please. This is just a table to show and provide a little bit of a flavor of how different those categories of people are. So we had the first row, low intensity, the medium low intensity, medium high intensity, and then control. Let's focus, for example, on employment. You can see that the higher is the intensity of care provided, the lower is the likelihood of being employed. This is the likelihood of being employed for low-intensity carer is 56%, but this goes down to 23% for high-intensity carers. Let's see income share. Low-intensity carers, up to 5 hours, contribute to the income share, so the household income, for 26%. This goes down to not even 9% for high intensity. Again, let's see, for example, male. We see that the high intensity subgroup is characterized by only 36% of male. 64 are women. Next slide. Let me give you straight away the headline of our findings. High intensity carer lose almost £200 a month in the 4th year after taking on unpaid care responsibilities. Next slide. I'm going to show you how and how to read this graph. So, horizontal line, we have the treatment time. Vertical line, the individual income monthly. Now you can see this red dashed line that goes in year 0. That is signaling us the onset of unpaid care responsibilities. In this very moment, in the year 0, unpaid care start to provide care for the very first time. Now, what you can see on the left side are those blue bar and blue marker. They basically let us know the difference between individual income for unpaid carers and their doppelganger, those people who look similar and do not provide care. As you can see, those bars always touch the 0. You can see that. This means there is no statistically significant difference between income of unpaid carers and their doppelganger, the one not providing care, prior to the uptake of unpaid care responsibilities. And then now you can appreciate how much the situation changed after year 0. There is a sharp decline in income for unpaid carers compared to their doppelganger, meaning that 2 years after uptaking unpaid care responsibility, they're already losing out £166 per month. And this goes in year 4, you can see the marker and read on the line. This is £192 per month. It's an incredible amount of money for an individual income. Next slide, please. Now, the graph before was about high-intensity carer, 50 hours plus, but we did investigate what happens when we consider different caring intensity. So we have the first graph top left, high intensity, top right, medium-high intensity, bottom on the left, we have medium-low intensity and then low intensity. Doesn't matter the intensity of care, prior to year 0, there is no difference in income between unpaid carers and their doppelganger, while once they uptake unpaid care responsibility, they all report a penalty. They all face a caregiving income penalty. I will summarize the percentage just in a few slides. Next slide, please. I want to show you now what happened to the income share, how much we contribute with the individual income to the household income. And just for time concern, let's focus only on the high intensity, first graph on the left. What you can see is that the percentage in which we contribute to the household income decline, and this is 4.8% less of my contribution to the household income in the 2nd year and 4.9% in year 4. Next slide. This has an impact on household income as well. Let's focus on the first graph. You can see that the first 3 red bar, they do touch the 0. Why so? Well, we can speculate about that, and we think is that the household, in the moment in which a person at household becomes an unpaid care, they start to activate this compensating mechanism in which they redistribute financial responsibility, they adjust their expenditure, they try to modify their approach. But then, as you can see, after a few years, these compensating mechanisms do not work anymore. And households do face a penalty in year 5 of £400 per month, which is an extraordinary amount of money. Next slide, please. This is just to sum up. We see, you can see on the individual income kind of column, a percentage for the penalty. This penalty is 45% for high-intensity carer, goes down to 22% to medium-high intensity, 13% medium-low intensity, 4% to low intensity. So we do have a penalty in any situation, in any scenario. However, the magnitude of the penalty does depend by the intensity of care provided in terms, in this case, of hours, weekly hours provided of care. Next slide. Now, as I said before, we try to explore the diversity of the unpaid care by sex, for example. And this is another headline feature. The financial impact of caring is higher for women compared to men. Next slide. We are not able, due to data limitation, to slice the data as we did before, so 4 categories of care, so high intensity, medium high, medium low, and low, but we can only divide the data in this case while investigating also the sex in high intensity and low intensity. In this very case, high intensity is 20 and more hours, low intensity less than 20. Very happy to come back to this graph. I will go directly to the table to the next slide. And here you will see that women do face a penalty for high intensity care, in this context 20 hour plus, of 30% compared to 25% faced by men. Next slide. And I think this is the most significant result, at least for while doing research I was really impacted by this result. Young carers face the most substantial income reduction, with penalty reaching £502 per month when compared to their doppelganger. Next slide. Again, I'm not going to focus on those graphs. You can read it in the same way as we did it before. Very happy to go on it after. But we divided the sample size here, the sample that we have, in 3 main groups. Young carers, those aged 25 and below. Then we have working age carers, which we divide in 25 to 64, and then we have 65 plus. Next slide, to summarize the penalty. So the financial penalty in percentage for young carer is 181%. This goes to 70% for those aged 26 and 64. And then let's not consider age 65 plus, because unfortunately the income variable that we use mainly depends on labor market incomes, hence is really an approximation what we have there. Next slide. And this is just to conclude. Our research questions were 3. First one, is there a caregiving intensity? Well, there is. We can see a shift occurring after taking on unpaid care responsibility. Second question, is there a relationship between hours of care provided and the magnitude of the caregiving income penalty? Yes, there is. High intensity carers are the most impacted by providing unpaid care. Does this magnitude of the caregiving income penalty vary by sex, age, ethnicity? I didn't have the time to show ethnicity. Very happy to share this with you later. But yes, there is a difference. Women are face a hardest penalty compared with men, and young carers do face the most substantial income reduction, with a reduction of 181%. Thank you.
Thank you. And to summarise all of that in the time you had was genuinely impressive. Dr. Becky Cooper for the first lot of questions.
Yeah, thank you so much. Really interesting. Just a couple of areas of clarification, if that's all right. So the result that you said you found the most surprising, I think, was the young carers' substantial income reduction. When you were running your models, did you have cause to look at why that might be the most substantial income reduction? I realised that you were modelling, but was there sort of additional information that sort of gave you an understanding as to why that is coming out as it is?
Well, for me, it was, what shocked me is the £502. Like, I knew they were facing a penalty, not to this extent. But I think, like, if I had to speculate on this result, I think we can really understand why, because they face the highest cost opportunity, right? Those are the people that, instead of dedicating their time to the education, to training, to build up work experience, they provide unpaid care. And this not only affect them in the short term, but they affect them in the long run. So they will always have less experience, less education, less work experience compared to young people who instead can invest in education.
Okay, so just to clarify for my understanding, when you say a substantial income reduction, is that you're calculating their future earnings potential, or you're looking at their sort of educational how are you calculating that?
So the penalty, the percentage that you see is the ratio between the average loss in the years that we follow, so 5 years, 6 years, compared to the pre-treatment income.
Okay.
So that we can actually contextualize in terms of how much they were earning even before and have a relative penalty. But if you don't want to face, if you don't want to see the relative penalty, you can check the numbers directly and you can see that in year 3 or 4, they face a £500 less. That's the average. And yeah, I'm just referring to cost opportunity because I'm speculating what can happen. What can happen is that they are not investing in anything else rather than unpaid care. We are considering 20 and more hours of care. How can they combine education, training, work experience as the doppelganger?
Okay, so it's, so it's opportunity cost you're looking at.
Yes,
in terms of
opportunity cost.
Okay, that's
yes.
clearer. Thank you. And for women, when you are looking at their substantial reduction, are you also controlling for things like previous maternity leave and other issues that sort of impact women's lives more, with sort of taking leave for other areas?
No, we are not controlling for that because unfortunately we have limitation due to data. So we try our best, but we try to find the closest doppelganger. So for example, we control for family size. That gives us an hint on whether there is a child or not, and so whether there is previous childbirth leave. We always compare the individual to the closest doppelganger. So we're comparing two people that statistically, as possible, are very close to each other. We are not comparing different people.
Okay, so you're sort of looking for averages and then statistically comparing them. So if I can just move you on, and I appreciate that you've obviously looked at this data and, I'm not expecting you to sort of design policy here and now, but based on the conclusions that you've come to, what do you think the government should learn from this research in terms of the reforms that they should be looking at?
So I'm not a policy expert,
no,
but I will try my best. So the main result here is there is a caregiving income penalty. Now, we are investigating further with our next paper to understand what is the driving force. But if you think about it, when we take in consideration the caregiving income penalty, our variable income takes in consideration labor market incomes. So we can speculate and say the driving force is reduction in working hours, change in occupation, or leave the labor market. So I think the most straightforward things to say is that we need policies that help unpaid carers to combine paid work with caregiving responsibilities. So for example, flexible work arrangement, working from home, paid care leave, you already know that, robust support system, for example, or target financial measure. So I was hearing before the lady here, she was mentioning the criteria for the carer's allowance. It's unbelievable there is still there is a limit for people who are into education. This affects young carers so much. And I think another conclusion is because it's so diverse, we need a target policy. We need to take in consideration that people do face this penalty differently. So for example, young carers, policy that can help identify them immediately to support them into the education, into the employment, and try to limit the short run problems that they face to them. Yes,
no,
sorry.
That sounds completely sensible to me. That absolutely, and as you say, the data back up what we'd perhaps we might talk about and say, well, it's obvious, but these data make it incredibly clear. Just one more quickly from me. In your appendix, and I know you mentioned it, there's the ethnicity comparator, and I know that you sort of didn't go into detail on your presentation, but I just wondered if there were was anything significant that you wanted to highlight with the ethnicity comparator.
So I think that what is significant here is that we need to investigate more, because I'm a little bit ashamed of the classification that we were able to do because of the data. Right. We only divide in white and non-white, and I think we are losing out so much variability in here that is not a good distinction. But we wanted to give a little bit of a flavor of what could happen. I think what we see here is that white face the biggest penalty, but the explanation is that also white, what we categorize as white, do have higher pre-income prior to the treatment. So quite expected. So that's why I didn't show. But this is something we are investigating further. 100%.
That's great. That's really useful. It sounds like there's a whole lot more research to.
Yeah,
Thanks so
absolutely on ethnicity. Yes.
Great, thank you.
Danny Wheels?
Thanks very much. Yeah, you've made my head hurt slightly by the amount of data and graphics, and I very much hated SPSS at university and statistics, so kind of flashbacks to my university degree and nightmares having to try and interpret data. But really interesting data, as my colleague has said. Just looking at the gender-based differences on slide 19 that you showed. So is my reading correct that you're saying that relatively compared to the relative level of income, the percentage is greater for women, but the real terms, because men's average incomes are higher, the real terms impact is still higher in men, but you're projecting relative value of income loss is greater.
Well, I
right?
didn't mention the value itself, so we can check it out in the graph before. So it's very far away, sorry, I'm very blind. So if we see female, high intensity, they are on graph A. Yeah. And then we have high intensity male on graph B, so left and right. So you can see that, for example, in year 2, they face £100 penalty, and the highest one that they face is £180 in year 6. For men, in year 3, we have £100 as well. The greatest penalty they face is £200 as well. More or less is the same, but it hits women hard because of
the relative percentage, because the total level of income. Because on your previous slide, you've got average loss being 121 versus 137 on the high. So the post-treatment average loss.
Oh yes.
121 versus 1. So relatively, there is a higher kind of level of loss, but relative to income, it's a greater percentage. So that's what your data's suggesting. It's about relative levels compared to previous income. Yeah,
so what you see in post-treatment, this is just the average of all the numbers that you see in that line.
I guess building on my colleague's question, again, I appreciate you can't make policy recommendations, but it would seem to me like that there's a case being made here that, as you said, care work doesn't affect everyone equally, albeit you could make a case that there's significant income loss for men compared to women, actually slightly more men compared to women. Relatively, the impact is a higher percentage of income. So kind of flat-based benefit, like carers allowance being a flat benefit, you could argue from your data that it would be better to target higher levels of intervention for certain groups who face a relatively higher level of payment.
So just to be clear, the relative penalty is already computed, is as it is. So it's not hitting men harder, because that already, the penalty that you see here...
Maybe I'm inferring the data wrong there, but I'm read post-treatment average loss, £137 in the high group for men, 121 for women. 137 is a higher loss than 121.
Yeah, but it's in terms of absolute term. What you want to see is the penalty.
My point was absolute, so in real income, so income terms, it's a greater loss, but as a percentage of the starting income, which is lower for women, it's a greater percentage.
Yes, but there is a lot of literature explaining why this is also happening. We didn't investigate this in this paper, but many previous papers do acknowledge that the pre-treatment income are lower for women for a reason. It's because there are social norms.
Yeah, of course, the nature of the gender pay difference. What I'm trying to get to is, at the moment we have a carers allowance system which is kind of a flat level. Yeah. And from your data about gender, potentially ethnicity, but more work's needed on that, there might be a basis for more targeted, higher support for certain groups who face relatively higher penalties.
Yes.
Do you think that's fair to say?
I think it's fair to say, but what really women will benefit for is helping in being unemployed. So in being employment, it's not really about the flat rate. I cannot really speculate on that. It's not in my experience. But what I can see from the literature, from the data, is that this happens especially because women are those who have to combine more unpaid care. And if you think about it, yes, the penalty is 30 against 25, but 64% of women are providing high-intensity carers. So we need to target a little bit women just because already they are providing more high penalty than anyone else.
Yeah, thanks. That's very helpful. And similarly, you point to kind of a 5-year cliff edge point, a 5-year penalty, where, as you said, initially there's household adaptation potentially causing relatively less loss, but at that 5-year point, I think it was, you said, there's that cliff edge where suddenly there's a big significant increase.
Can we go back to the household income slide so we can contextualize a little bit better? Income share, household I didn't mention that there is a change in year 5. I only read the highest penalty that is happening in year 5, £400.
Yeah.
So we don't have any, I cannot speculate on when this happens and when there is this threshold effect. What we can see from our data is that in the first 30 years, they're trying to compensate.
Yeah.
But then something happens. They cannot handle the situation financially anymore, and there is a drop. And I only read the highest penalty they face in year 5.
Yeah.
So I cannot say this is the point in which something happens.
That's helpful. And as well as, you've controlled for kind of a doppelganger, have you done any international comparison?
That's our plan in the future.
I think that would be very helpful to understand international comparisons. And would you also be able to do a kind of doppelganger analysis for other forms of unpaid work? I think particularly childcare. Would you be able to control for kind of childcare, which is significantly unpaid, and the relative impacts on someone providing childcare to unpaid care?
I'm working on a paper actually on childcare that does exactly the same estimation. And in terms of comparison, our team, my colleague and I, are putting forward a bid to have some to win some grant. And basically what we want to check is comparing policies that are adopted in other countries to actually see what works, what doesn't, and where UK position itself in terms of economy and care regime, and what can be adopted in the UK, and a cost-benefit analysis of those policies. Really, this is in our plan.
Sounds like that's exactly the sort of thing that we were hoping to kind of glean out, but that sounds very helpful work. Hopefully your bid will be successful.
Me too.
Yeah, it sounds very useful. And just my colleague said, just to clarify, it's just pure income-based, projected income loss. You're not taking into account positively or negatively the impact on pensions, the impact on broader benefits and welfare, both positively and negatively to your individual.
Sorry, I'm laughing because you are basically reading my bid at the moment. So yeah, that's basically what we are trying to write is the next things that my colleague and I want to focus on is going to be, first of all, trying to understand the driving force. So working hours or leave of employment or change into occupation by age, job type, category, everything. Second is an international comparison, try to see what policy work, what doesn't. And the third is actually to understand even the long run effect. So, for example, as you mentioned, the pension problem, assets problem, to understand also the long run, which are known to be very gendered in terms of problems. So, yes.
I think as a committee, we've been kind of conscious that potentially an audience for our report would be the Treasury rather than Department for Health, and they're making these cost-benefit analysis is about a series of interventions for a series of population groups, and being able to weigh into, relatively, as you say, we know what the income loss per people is here, but we don't necessarily know what the impact on the Treasury is from lost taxation from that income versus, potentially benefits from the cost of paid care, if that would be, or other financial support if that were the intervention that was needed. So it sounds like your bid would be very helpful. Yeah,
it will be a cost-benefit analysis to see who benefits, who doesn't, how to implement this.
Mm-hmm. Yeah. Just lastly, before I'm sure my colleague wants to come in. So in terms of the kind of spread of intensity, so is it fair to say that there's a kind of sweet spot around the kind of 0 to 20 hours level of care where kind of
you want to refer to some graphs so I understand?
Possibly, it probably is helpful for my understanding to see a picture, to be honest, in terms of, so if there is a relevant graph. But from what I was reading in your presentation hearing, is it fair to say that there's a kind of, no loss is acceptable, for a person, but in terms of the significance of the loss, a kind of 0 to 20 hours level of intensive care is more, as a more manageable level for...
Yeah, well, I don't know what is manageable or not for people, of course. people are characterized by different kind of income stream. But yes, the literature knows that there is a threshold effect at 20 hours of care. So many papers confirm that already, that from 20 hours, people start to really struggle financially. So I think we confirmed somehow that, even in the shape kind of graph that I presented before, you can see that, this is just raw data, just data not cleaned. But you see that the big change is with the green and red line, a little bit with the yellow as well. But green and red line, you can see a sharp decrease of the curvature. So I think what you're saying and claiming is right.
Thank you very much. That's really, really helpful work, and good luck with your bid.
Well, thank you.
Happy to provide a letter of support personally.
For if possible, can we go back to that last slide? Can I just ask about the uncertainties in the data? Because I'm quite struck. Where is that graph? There it is. So for medium high intensity.
Oh yeah.
I noticed that if you take the uncertainties into account, actually one might argue that there is no change.
So we justified this in the paper. It's not that there is no change, it's that there is a lot of noise in the data. And this is because...
Why is there more noise in that group, it would seem, than other groups?
Yeah, I'm explaining this. So low intensity is 0 to 5 hours. Then we have 5 to 19, and then we have 20 to 49. That's a big portion of people. Unfortunately, the way in which the data are collected do not help us to disentangle and stratify this category more, hence why this problem. But we think it's too many individuals provide a wide range of hours of care, and so hence the noise.
Noisy, thank you. Joe Robertson.
Yeah, thank you. Thanks very much. I think without us somehow, and I appreciate this wasn't the purpose of your paper, sort of explaining some of this, it's going to be hard to make arguments with Treasury or government as to the reasons why some of these things. So if I could look at because a lot of your answers seem to be sort of unexpected. We're sort of sitting there thinking, really? So the young people, so age 25 and below, having the biggest financial penalty from a caring role. Has anything been taken into account of the household situation in which those people exist? So it could be, I don't know, but I'm speculating, that if you're aged under 25, there may be other earners in the house earning significantly more money than you could earn. So if you take on a caring role at that age, you might simply not enter the workplace at all. But you can only do that because you are still, broadly speaking, maybe living with your parents yourself. And that could be an explanation of why that penalty is so high at a younger age, is because too many people simply don't enter the workforce at that age because of the caring role.
Yeah, I think this is exactly the explanation as well. They cannot enter the workforce, and this is a big problem probably. In our estimation, we try to compare these unpaid carers to their doppelganger, trying to account for all possible characteristics that available in the data. We do control for household size, as I said before, that should take in consideration, a little bit of this aspect of how many adults are in the household, and we compare, for example, if the unpaid carer has one adult and it's made of two people household, the unpaid carers and the adult, we compare this with a similar person, a doppelganger that is in two size, like in two people household. So then we average out the effect for every single combination, every single treatment with untreated and treated with the doppelganger. We average this out, and this is the total effect. Now, I didn't investigate what happens next, because otherwise it's going to be for a future paper, really. But we can only speculate. And what I said before is that if they are losing out so much compared to a person that is completely the same, household size, gender, education, everything, then the only thing missing is that they are losing opportunity. Because the other person, the doppelganger, can go and build up work experience, can go and do a training, can go and invest in education. This person can't. And so hence we see a decrease in income, on the possible income that he could have earned if he was not providing care.
So I would suggest the explainer it's not necessarily age per se, but it's that people under 25 are only more likely to be living in a household where there's another higher earner, possibly two more higher earners. So compared to their doppelganger, under 25, most people probably have more freedom to decide whether to work, to go into education or not, because they're more likely to be living there with their parents than someone in their 50s. That's why you've got the difference. So it's about the household environment in which under 25-year-olds are more likely to exist rather than their age per se.
I wouldn't be able to answer to this question. We didn't investigate any further. What I'm providing is just speculation,
Sure.
really.
Can I just ask about the difference in gender as well, which I thought was quite interesting, or difference in sex? This idea that if you take a male who is providing, take high intensity care, compared to a woman who is providing high intensity care, that her financial penalty will be greater. That's correct, isn't it? I think that's what your data shows.
I'm saying that the relative penalty for women is greater than the relative penalty of men.
Which runs against the sort of anecdotal evidence actually that we've heard earlier, this idea that in traditionally male breadwinner jobs, that it's harder for them to adjust within that role, so they simply don't do it, and it's left to the woman more likely to give up her job or go flexible. Your data runs against that, because I think what you're saying is if a woman provides high intensity and a man provides high intensity, so you're forgetting this idea that the responsibility shifts to the woman because you're comparing a man who is providing high intensity and a woman who is, somehow her financial penalty will be greater, which suggests that he has more job flexibility to do the intense work and retain an income. And I don't understand how that happens.
Again, it's speculation. We didn't investigate this further, but one of the things is like maybe women can be hit hard because there is literature out there of my colleagues explaining that women do expect to care, and so they self-select themselves in different occupation that allow them to have a little bit more flexibility. And this is even a bigger problem because they are constrained to select some occupation just because they know that they are going to care.
Surely the doppelganger's doing that already. So I take it there could be that just, of course, gender gap unfairness that women have this sort of almost preparing in life to be flexible in case, but your doppelganger's already doing that, and your comparison is
My
with a
doppelganger is a woman as well.
Yeah, sure.
That could think that in some point in the future will care.
Yeah, so your doppelganger, if there's sort of structural unfairness in that, and I guess there probably is, your doppelganger is already doing that.
That's all I'm saying. There is structural unfairness. That's my whole conclusion here.
So I still don't quite understand why the man who provides intense, high-intensity care is hit less financially, because you would think that he's not in a job that says, yeah, we'll keep paying you and you can do that 50 hours as well.
Well, I think a next step to know that is to understand why, and so whether men have more flexibility in work, whether men can reduce, it's just about reducing.
Still get paid. It would suggest men should be doing a lot more because they seem to be able to retain their income and do high intensity care, which seems to run, that's what the data's saying, and it runs contrary to what we sort of think or see around us.
I'm not able to answer, I'm sorry. Just
no,
like I can only say what I see here, but that is extra speculation that we want to address. This paper is like, we finalized it 3 months ago. So we really didn't have the time to investigate this further, but I understand your concern and your questions, and it's something that we definitely have to look into. So
Great. Thank you very much. Thank you.
No, sorry, I wish I could say more.
Thank you, Josh Fintingland.
Thank you. I just want to draw you back to this young carer who's down 181% or £502 a month, because obviously that's the most stark statistic, and actually, and I just wonder, and I'm perhaps asking you to speculate again, but obviously one of the biggest indicators about having a higher percentile income in your later life is having it in your early career, and I just wonder if what kind of impact you think, kind of looking at the data that you've produced, caring responsibilities for someone when they're young will have on their ability to work to contribute to the economy, to contribute to the tax base, going back to Danny's point, throughout their career. And I wonder if you think that will in fact become an even greater gap because of their caring responsibilities.
Oh yeah, it could be. Again, it's I'm not sure I can answer this question directly, but it's something that is worth investigating in. Mm-hmm. And yeah, I wish I had all the answer, but...
No, I appreciate that. It's, I'm asking you to sort of speculate wildly, but I think I'm just caught by just the starkness of that, and just thinking, if we're, a case one could make to the Treasury is actually, supporting the young carers is even more vital, because actually otherwise you're setting them up for a career whereby they massively undermeet their earning potential, as it were.
Well, I write down all your concern and curiosity, and I will be the first one to let you know as soon as you discover
we'd be very
more.
interested in all of your future work.
Oh yeah, thank you.
Alex McIntyre.
Thank you. Just to follow up on one of the questions that my colleague Dr. Cooper asked about the opportunity cost, because we heard from Jayne in the previous session that as your caring responsibilities intensify, then there's naturally a drop-off in your capability to work more hours, and that seems to be the logical conclusion from the graphs that you've shown, which is the high-intensity group are physically less capable of perhaps working, and I'm making the assumption that the doppelgangers, the assumption is that they continue in full-time work for the most part, as kind of the average person would. But have you done any kind of extrapolation to see whether there is a reduction in the wage earned per hour that the carers are able to work? Because I'm conscious whether there is a bias that comes in that kind of compounds the opportunity cost, which says because you're caring over a period of time, that actually you don't then progress into other roles because you aren't able to continue with your career, and whether that has an additional cost on top of the impact of not being able to work additional hours.
We didn't. We basically developed this method in 2-3 years, and we are now ready to apply to all sorts of research questions. So understanding the impact that we see here is our main objective now, is what we want to do. So we want to understand why there is this decrease, and it can be for a million possible questions. So we're going to focus on the employed population. We're going to try to understand the before and after in terms of wage, in terms of working hours, shift in occupation, participation in the labor market. Those are all next steps that we want to consider. But yeah, we didn't see that. And in terms of the doppelganger exactly mimic the unpaid carers prior to the event. After, it just shows what will have happened. So they are different.
Well, Dr. Petrillo, thank you so much for your time. Hope that wasn't as scary as an e-Viva. So thank you. We will now move on, please, to the next presentation. Thank you.
Thank you so much. Thanks.
Absolutely.
A really good one. It's amazing.
We now move to our second presentation. Thank you so much, Tom Gentry and Caroline Abrahams, who are going to present to us the state of health and care of older people in England, commissioned by Age UK. Over to you.
Over to you, Tom.
Thank you very much for the invite. And just to briefly introduce myself, I'm the Joint Head of Health Influencing at Age UK, so overlooking a lot of the health and care policy work we do, and one of the co-authors on this report. Go to the next slide, please. So just briefly to introduce the report itself, it's an annual report that we've been doing since around 2015. We want to look at some of the key metrics around populations and ageing, what the access to social care is looking like in the previous year, and levels of unmet need, the impact on NHS services and some of the funding decisions that sit around that. And we just take some of the publicly available data and put some of our own analysis to it, and obviously put on some commentary. So next slide, please. And again. So we always start at the top to remind people that we are in a very rapidly ageing population at the moment. So the next slide, please. As you'll see from this graph here, we project that there'll be 4.3 million more people over 50 by 2044. And as you'll see quite clearly, the fastest groups that are growing are the oldest old, so the 80 plus, accelerating at a faster rate than others. Next slide, please. But we also know that healthy life expectancy is in decline. So this is the number of years you can expect to live in reasonably good health on the one side, and also disability-free life expectancy, so the number of years you can expect to live without a disability. On this graph here, going back from 2016 to 2022, it's shown that if you're age 50, you have around about 20 years, whether you're male or female, of healthy life expectancy left. And on average, you'll live for about another 30 to 34 years at 50. And again, disability-free life expectancy, although there has been some COVID effect in that, I think, there is a pattern of decline across both those measures for the last 10 years. Next slide, please. And it's not evenly spread, which again will probably not come as a surprise to people in this room. If you're living in the northeast, you can expect to live far fewer years with healthy life, disability-free life, compared to those in the south and southwest in particular. And obviously behind this is people that have higher levels of need and poorer outcomes at the end of their lives. Next slide, please. And again, this may not really come as a big shock to people, but as we get older, that we do have more difficulties of activities of daily living. So these are things like washing, dressing, going to the toilet, basics of daily life that, as you can see from this graph, really accelerates in that 80 plus age group. So 1 in 10 that are 80 plus have 3 or more difficulties with activities of daily living, as they've self-reported that. And a very large proportion overall have at least one. Next slide, please. And next slide, please, again. And how is this playing out on systems? So what this graph is showing is the number of new requests for support going back to 2018-19. The thin line at the top is the total number of requests, and the blocks at the bottom are the numbers of formal support delivered in response to those requests. There are obviously some, the sort of thin lines in those blocks at the bottom are the long-term support ones. The larger ones are generally short-term support. But as you can see, very large gap between those that have requested it and those that receive something after that request. I think within that gap is a lot of people that get signposted, so they're sort of passed on to other services, notably places like Age UK's locally, who provide some extra support services that aren't formal. But there's certainly a gap there between those that need support and those that get it. But we also noted in the report that the waits for those assessments are getting longer as well. So this is using last year's data again, because it's from last year's report. 1 in 3 of those that have requested a care assessment are waiting 6 months or more for a response to that. And again, almost 2/3 of councils are having to prioritise the sort of higher risk ones, such as those where abuse is highlighted, those around hospital discharge in particular, and some of those temporary periods of residential care. And there's a couple of quotes there of people that have said what that impact can be on them. Next slide, please. And this plays out on the numbers of people that are receiving formal long-term support from their local authority. And this has been in decline since 2017-18. So we do know that the amount spent on long-term care has been creeping up slightly, but the numbers actually receiving it have been going down. So it suggests there's much more complexity in the system, so fewer people are getting more care or more intense care as part of that picture. But on that basic equation there, that's 25,000 fewer people receiving long-term support. In that same period, we also know that the numbers of people that are over 75 has grown a significant amount. So 18% more people over 75 in that same period. And as you can see from those earlier slides, they're the ones that are most likely to need that support, but fewer people are actually getting it. For the next slide, please. It's quite a difficult one to read this one, but this demonstrates some of the variation in the capacity in care homes. So on the one side is the total care homes by region, which is in itself shows there's quite a lot of variation between the capacity of care homes across different regions. But both bed capacity and total care homes, again, has similarly been declining over the last 5 to 7 years. in every region across the country. But even within that, there's big variation between regions of capacity. The next slide, please. And some of this plays out in how many staff are available to do these things. So we know the staff vacancy rates have been steadily climbing for the last 10 years. Obviously jumped significantly during the pandemic and come down slightly since then. I think some of that is being filled in by workers coming from abroad. But across all major social care service providers, there's very high vacancy rates, so above 10% of all roles in domiciliary care are currently vacant. And that's also played out in the turnover rate. So those people that don't stay in their job for a significant long period of time, those turnover rates again have been climbing, arguably even much quicker than the total vacancy rates. So I think some of that is played out in that stat on the side there around staff rate, about salaries. So a senior care worker on average is paid between £11 and £14 an hour, which is roughly similar to some retail jobs in that sector. I guess that's just demonstrating that junior care workers paid even less, but equally the pay progression for those workers is remarkably slow, really, that even if in a senior role, your salary is going up by quite nominal amounts. Next slide, please. I think some of it just plays out in just the comparison between the number of staff and the money spent on health and social care respectively. So on the left side, the total number of staff is relatively comparable. So the number of people working in these sectors are the same, but the spending on health absolutely dwarfs that spent on social care by a very large amount. Next slide, please. So of course this is all having an impact on older people themselves. So this is one of the major stats we put out with this report is the levels of unmet need, and our estimates for last year, there was 2 million people over 65 that had an unmet need for social care. So that's someone who described having difficulty with an activity of daily living and doesn't get enough support to meet those needs. And here's how they play out across different categories, such as dressing being the main one, that they're least likely to get that support, but also getting out of bed, eating. These are things that are not being delivered to people. We can't directly compare them, but that first report I mentioned, this figure was around about 800,000. The last comparable figure we have for that was 1.6 million from last year. We had to calculate it slightly differently in this version. But in the comparable period, that unmet need figure doubled over the course of about 8 years, according to our analysis. Next slide, please. And then you've heard already about the impact on carers. This is how the number of hours that people care on an average week is spread out across the age groups. The largest block is in that sort of 55 to 64 bit. That's where you're most likely to be a carer. More typically the sort of daughters and daughter-in-laws or fathers and grandparents. But as you get older, the proportion of your time spent caring increases. That purple block at the top are those that are caring 50 plus hours a week in their care. And that's mostly going to be co-caring couples and people that are caring for partners. But they obviously brings complications of itself because they're also having their health needs compromised by that caring relationship. But a huge burden placed on older carers in that period as well. Next slide, please. I guess briefly, that also reflects how easy it is for people to step away from caring roles. This is the proportion of people that can report being able to take a break at short notice or in an emergency. So yeah, over 85% just can't take a break if they need to at short notice or where something has come up. So yeah, and that's again a number that's been increasing over the last 10 years. So more people are in that position compared to 10 years ago. Next slide, please. And how that impacts the hospital sector, I think, is another big one. So this is the number of people that are having long stays in hospital. So the three sections there are those that have been there for 7 days or more, those that have been 14 days or more, or those that have been 15 days or more. So these are the long stays in hospital. I guess the point behind this is that I guess what we're seeing is there is a level of deconditioning that's happening at home. So without some of that care and support, people are declining at home. They're under eating, not hydrating enough. They're put at risk of falls. There are lots of things that are going on to the point where they need an admission to hospital. When they're in hospital, that itself can accelerate that deconditioning process where you get muscle wastage, you get delirium, there's falls risk within hospital itself as well, hospital-acquired infections and big mental health outcomes of being stuck there for a long time. So I think and again, that number did jump during the pandemic, but they remain very high for those that are staying in hospital for long periods. Next slide, please. And part of that is explained by those that are delayed in hospital. So again, it's a very small graph to read, but what that's telling us is these are the people that have been in hospital for 14 days or more, but are now at the stage where they're ready to be discharged, but they're unable to leave hospital. Those three long lines at the bottom are effectively the main social care indicators for that. So if you're waiting for an assessment to get care at home or a bed in a care home, that's representing around sort of 20 to 25% for each of those alone. So people can't get out of hospital because they can't get that social care provision put in place quickly enough. That has knock-on effects. That's a big reason why A&Es are so overheated, because the long waits for those that want to get into a bed but can't have one. And just as a brief comparison, they count this slightly differently now, but when they used to count this under delayed transfers of care, usually within an average day, it was about 4,200 in that 16-17 period that were delayed in this fashion. The most recent figures, and that's from 22-23, but this is virtually unchanged to today, it's around sort of 12 to 13,000 people on a typical day are delayed in hospital for those reasons. And the further effect of that is that 1 in 6 of those people over 75 that are then admitted in an emergency have been in hospital in the last 30 days. So even if they get home, they're coming back in again. Come next slide, please. So I guess to sort of summarise that, we have an older and ageing population. We're seeing an increase in complexity, just partly because there's more older people in that older age group and they're more likely to have those needs, but also because of some of these systemic issues around how health and care is delivered more generally, that there's increasing complexity there. That level of unmet need is continuing to grow. That has very real impacts on people themselves, but also puts additional strain on the NHS when crisis comes. Carer strain is again going up. We saw from that graph that it's much more difficult to care today than the last few years, and that increases pressure on hospitals and causes partly there's a big explanation for why a lot of the funding has to end up gravitating towards hospitals, because they have to meet that need where it arrives. There's a big loss of intermediate care, reablement and rehab support, the sort of thing that when you get home can help you to recover well and stay at home afterwards. And then in more recent years, some of the cost of living challenges have added even further pressure to that. So those people that may have picked up the bill themselves when they could, they're feeling less able to pay for those things in the current climate. So even more unmet need coming from there. I'll leave it there, and thank you for listening.
Thank you very much. And that was a lot of work summarised in a very short amount of time, so well done. Andrew George.
Oh, thank you very much. That's it's a very depressing picture. So just in terms of getting clarity on the figures that you've given us, in terms of those that you're saying have significant unmet need. You're saying that there are a number of people who are simply not eating because they're not getting the care.
It'll capture. So the way it's captured is we ask people, do you have difficulties with these activities? Yes. And so we'll say things like eating, with dressing, going to the toilet, and do you have support to have those needs met? And it's those that reply no to that or not enough is captured within that. So that'll capture people that yes are not eating at all, right down to those that are not eating enough or not eating correctly. So
we're talking kind of millions that are not getting dressed.
It doesn't quite mean that, actually. Sorry? It kind of means, actually, I'm going to struggle to do this on my own. If there's no one to help me, it's going to take me a long time. I might not fully manage it. I might be at risk of falling over while I'm trying to get dressed. So it's more that, actually. So
there are obviously gradations, but
yes.
So you also gave figures in terms of the reduction in care home beds and so on. Were you able to disaggregate between nursing care and residential care? Which is experiencing the greatest decline?
We have done that. I don't think it was in last year's report, but we have done that. I think we know that the numbers of registered nurses working in the social care sector has declined significantly. So I think we included this in this predecessor report. I think we estimate around 40,000 fewer nurses working in social care. So that will reflect on both nursing homes themselves, but equally nursing capacity in other residential homes as well. So I think nursing capacity is under strain. And that, I think partly that to explain that with that differential in the figure being spent, as we saw, but obviously working in the NHS can be a lot more attractive for people that have that qualification, and obviously better pay progression, all those sorts of things. So you do find, especially through periods of general financial hardship, that people move over to the NHS because they've got a better chance of a career there.
Right. So it's workforce shortages causing the reduction, not the proprietors deciding to get out of the sector, is it?
It'll be both. Okay. Yeah. There'll be some that it's not affordable to deliver those services anymore. I think that's we're going to hit a hard wall of that next month as well.
Yeah, I mean, you say that there's been an 18%. I just want to check this, 18 or 18.2%, I think it was, increase in the proportion of people living over the age of 75 since 2017. I think.
Yeah, so
it's very dramatic.
The numbers
increase.
of people. Yeah, I think we're kind of in the baby boom period now, where that 70 to 80 category has been growing exponentially really for the last 10 years because of that bulge that came out the post-war baby boom. So
and the previous presentation was saying that there would be a doubling of those over the age of 85 by 2045. So all of this is building up a very, very significant increase in care needs going forward. So I mean, one aspect which obviously concerns us. I mean, it is an issue which we are going to have to get our heads around in the report in terms of the cost of inaction, and that is the delayed discharge, those who are medically fit to be discharged. I mean, you've again provided a lot of very helpful figures on that, but many of the packages, particularly in pathways 2 and 3, will require a package of jointly primary care and social care, and to what extent? I mean, the whole idea of having integrated care boards was to actually break down and to encourage the working together. So, have you seen any kind of change since 2015 over the last 10 years while you've been doing this? Have you seen any kind of improvement in terms of integration?
Patch, isn't it, Tom?
Yeah.
I mean, there are some places that have moved ahead and have done quite well with integrating their services, although...
Like where?
I wouldn't want to name them just offhand, but...
I mean, can you supply that to us? Because I think it would be really useful if you had
absolutely,
example of exemplars.
Yeah, but of course, the problem is, if you haven't got enough social care staff and you haven't got much of a social care service locally, it's really hard to integrate that care. Secondly, this isn't the focus of your inquiry, but there's a huge shortage of district nurses and community health services, and what typically older people discharged from hospital are likely to need is a bit of support from the primary health care, as you say, but even more so community health services, district nurses to come in and change dressings, that kind of stuff, and social care. So you've got to have all those people, and you've got to be able to join us all up for individuals, and there's shortages across all those. I mean, dire shortages. The point is, we've got an ageing population. You'd expect the system to have kept pace with it and to have expanded if we were being kind of logical. But instead of which, it's either stayed the same or gone backwards. So that's why we're seeing these big gaps.
And are you seeing, just in that area, a push to reduce the requirement of packages of care in a residential care home or nursing care home setting? And if you like, for financial reasons, pushing people to, well, not pushing people, but preferring or seeing whether they can get away with providing that care. I
wouldn't put it like that, to be honest.
I probably use pejorative terms.
No, it's fine. But I think there's a strong consensus that it's absolutely right for most people, if they can, to stay in their own homes. It's what older people want. It's better value for money for the taxpayer as well. Yeah. So there is a definite shift. But if you're going to do that, then obviously you need to be able to brigade those services around an older person. Yeah. The government is going to be bringing forward its proposals in the 10-year NHS plan, and also the neighbourhood health service soon. And that's all about joining up primary care with those community health services. But we're still going to face the problem of not having enough staff, and historically not having enough staff and needing to scale up really quickly, I think.
Right. I mean, just if I'm allowed one last question, just with regard to discharging, there is some anecdotal evidence that there's spare capacity in nursing and residential care homes that isn't being taken up, and therefore, to save money and to move the system forward, that actually discharge to assess in a care home until a final decision is made, surely is not an option which is worth pursuing. Is that anything
it
that
may be,
concerns?
But the downside of that is once an older person goes into a care home, they may get stuck there.
Okay.
And it's not very many people go to a care home and come out again.
Right, okay.
So the risk is somebody goes into a care home to be assessed, is less mobile, doesn't retain their independence, doesn't get the rehab that Tom was talking about being so necessary, and then they're stuck, and then it's down to the family and the older person to pick up the bill, which may be enormous. So it is probably, the other thing is all care homes are not the same, as I'm sure you've heard in your inquiry, and it may be that some of the ones where there are spaces are either in the wrong place or they're very expensive and they're charging more than commissioners are able to pay. So that's what happens when you have such a mixed market, I think.
Okay, thank you very much.
Thank you very much. Joshua Tingley.
So I want to go back to the kind of particular partners caring for one another and those circumstances, because I think this plays into the kind of broader cost of not doing care properly, because obviously you talked about there's a significant impact on the health of the partner who's doing the caring responsibility. In my experience as a cabinet member for social care, I saw that particularly with men who would refuse to get help yet to get quite a lot from their wives. I mean, firstly, I'd say, is that something that you'd kind of recognise is borne out by the data in terms of the impact of it? And also kind of, would you kind of speculate, in terms of the hospitalisations, how many of them are because people are kind of reticent to get the caring packages and therefore much more relying on their partners?
We don't hear a lot about that. I would think it would be fair to say. We don't hear a lot about men refusing to accept care and only wanting it from their partners. I think it's more that in lots and lots of people's lives, couples just expect that they're going to look after each other if something goes wrong. They don't even view themselves as a carer. It's just kind of what you do. And that's fine, and I don't think we want to discourage that, but it's a really hard thing to do if you're doing it all on your own. So part of the problem is the lack of backup for people. It's one thing to be a primary carer for someone but have a really good suite of services coming in to support you. It's another thing if it really is literally you, and say you're supporting a partner with dementia who is uncomfortable if you even walk out of the room. It's people in those sorts of situations who are under the most immense pressure, and those sorts of people need a package of care around them to support the whole household, really.
Yeah, and respite is something that I definitely have seen a lot. And do you think that has a longer term health impact on the caring partner?
Absolutely, yeah. I'm speaking as an ex-carer myself. I'm sure there are lots in the room. You're just focused on the person you're looking after, and it's very easy just not to think about yourself at all. And then suddenly, 2-3 years on, there's that thing you hadn't quite dealt with then, which might have got a lot worse, because you might not even have the time, as Tom's slide shows, to go away and actually make the appointment to see a GP. So I think that's the trouble, really. That's why it's great for, as I say, don't want to discourage people from caring. It's what people want to do. It's the right thing to do, but we do need to support them better.
Do you think that the level of support has always been bad, or do you think that it's got worse as council budgets have become more stretched?
It's probably a bit of both, I think. I don't think it's ever been great, but these days, even if you're entitled to a carer's assessment, how long you have to wait to get one and what, if anything, emerges on the back of it is quite debatable. So I think it has got harder as Tom's slide shows, the pressure on council budgets have led to them having to ration a lot of their support, frankly, and have to, as you'll have seen as a councillor, not that anyone wants to do that, but it's put councils in an almost impossible position. And carers tend to get squeezed out at that point, I think, understandably, but that's really tough.
The thing is that, yes, that raising the thresholds, I think we you don't have to go back that far to think about this idea of moderate care need, where someone has the early stages of needing something, and that can really, there's a fork in the road for many people. And we observe that with things like frailty, which is a big issue we talk about, where people have low physical reserves to respond well to things. And they talk about this tipping point when they first needed to ask for help and not getting it. The acceleration to dependence is much, much quicker from that point onwards. So I think that chance to intervene early just doesn't exist in the social care world as it perhaps once did.
I think one of the things we found in my council was actually if you got in early, then actually the rate at which people decreased was much better. And there are also some things that you could do early, like assisted technology, which would, like tracking watches and things like that, which people would get used to even with early stages dementia, which they would then be able to continue to use. But if you don't kind of get in early, then you miss that saving later on down the line.
And to think of that example you used about refusing care, I think people are much more ready to accept lower level care, like smaller adaptations, rather than the kind of what can feel like invasive care that comes further down the line. So you've got a much better chance of getting a response from them as well.
Hamilton.
Good morning, both. I'm going to go back to the title of today, Social Care Reform and the Cost of Inaction. Now, like Josh, I led social care in Birmingham, which is ethnically, it's very diverse as a community. Now, what we found in Birmingham was people from large numbers of our ethnic minority group. That includes parts of the Irish community, that included Gypsy, the Roman community, Black, Asian community especially. They didn't access social care at all. They did the caring within their communities. Now, going back to the cost of inaction, if we're truly saying that at the moment everything you've said is correct, what would happen if, say, 50% of the people that currently do not even access the care that they so deservedly need come onto the market? Remember, the kids are working away. They're now not looking at, say, in the Asian community, working in local corner shops. I'm just giving you the context. What would happen, in your opinion, if these people then tried to access care? What would be the cost to what we're trying to offer at the moment? I'll throw it open to you guys. I don't care who answers.
You know the answer to your question, which is
I
the
do,
whole
but
system.
we're on film, and I want the answer from the experts.
I think the whole system would. I mean, it's buckling now and finding it really difficult. I mean, how would it be for Birmingham City Council in that situation to suddenly have, what would it be, thousands more people wanting an assessment, appearing to have an absolutely valid need for care, which you would have absolutely no opportunity to fulfil, even if you're one of the councils that has tried really hard to sustain a local level of support type of infrastructure like Leeds City Council has. I mean, even that wouldn't be enough, I don't think, and I guess you would see then a complete system collapse, really. That's part of the problem with social care, is it never completely collapses, so it's easy for people to think it's not really in crisis, but I think something like that would definitely precipitate it.
So as people who are, I'd say, experts when it comes to looking at the elderly and care needs, what would be the two things you'd like to see? If you had a vision for the future, you want something in our report, what would you like to see happen in the future around social care, the inaction, and what could we do next?
Well, obviously we've got the Casey Commission about to start. I hope that can happen quite quickly. Basically most advanced countries reformed their systems 30 years ago, in the late 1990s or the early 2000s, and we are really late to this party. And the one good thing to be said about that is there's lots to learn from other countries. So I hope that we will look outwards and not just look internally in the UK, and look beyond, try and learn from countries like Germany, Japan, and the sorts of things they've done is they've recognised that social care needs to be part of our infrastructure, and so we probably all need to contribute a bit through our lives so that if and when we need social care as older people, there's a minimum standard there for everybody, which we might be able to or choose to top up in various ways. But at the moment, there's nothing like that for people who are absolutely on their own. and as we've seen, more and more of them not being able to get care at all.
So, Caroline, you've highlighted one thing that you've seen in Japan about more contribution. What about yourself, Tom? I always say 2 because that's my famous number, but even if you could give me 1.
I think that relationship with the NHS is a really big one. I mean, part of that picture around delayed discharges is because I think in a lot of areas there's a complete dysfunction between that divide. Some of it is funding, because the funding doesn't go quite where it needs to go easily. Some of that is just about relationships or just co-locating staff. So you have social care working alongside NHS staff rather than working in silos with each other. So I think from my perspective, I think, and you know, it's partly delivering on the promise of ICSs, because they were there to bring together, you know, health and social care in a more systematic way. And I know that's all up in the air a bit at the moment because of the demands being put on them to cut staff and other things, but I think really having a sort of sea change in how that relationship works has to be acknowledged within the 10-year plan, I think, as it comes out, but also needs to be captured within the KC Commission as well. So and the older people are the ones that are most likely to rely on both for very long periods of their final years. So they have the most at stake, I think, for them getting that right.
And that's a good place to start. Back to the chair.
Thank you. Last question, Andrew Drew.
Okay, but yes, there's been passing reference throughout the evidence session today to respite care, and it's often kind of seen almost like an icing on the cake to what's fundamentally needed to be provided. And I just wondered where you were in terms of seeing how the picture has changed over time, over the last 10 years or even further, because it does seem to me that all of those providing care do need a breathing space and a chance to kind of recharge their batteries and look after their own health and well-being.
It's not something we've captured in the data, but we do every year do polling and survey an exercise with older people and carers, asking how they're doing, what they're missing out on, those sorts of things. And absolutely, from the responses we've got from that, there's been a huge decline. I think there was a steep decline during COVID, because obviously everyone was in the same houses, and a lot of pressure put on people for those periods. But yeah, I think just very frequent they'll come back and say that thing I used to use isn't there anymore. Yeah. We have our network of local age UKs who deliver all these services. They're really struggling at the moment, and I think they will struggle more going into next year with the national insurance rises. So I think the availability of those things, I think that was one of the big things that came out of the survey at the end of last year, is those low-level services just not being there for people. That's definitely jumped up the list of responses.
I mean, you're in a more advantageous position than I, but certainly over the last 20 or even 30 years, it seems to me that references to the availability of respite support seems to have declined and it seems to have almost sort of fallen off the radar in many locations. I just wanted to get your impression of whether there's any quantitative data which kind of supports the anecdotal evidence which I'm picking up.
No, plenty about that. But I think it's also about capturing that, you know, some things might not be formally recognised as respite services, but that's exactly what they are for a lot of people. I think, again, that's what a lot of local HUKs will be providing, are those, you know, social clubs or spaces that people can go to. And it's the chipping away at those, I think, that has had a cumulative effect.
Okay, very much.
Well, Tom and Caroline, thank you so much for your time. Thank you to my panel, but thank you to everyone who gave evidence today.